This presentation, titled Point of Care Hemoglobin A1c Testing, provides strategic advantage for monitoring and treatment of diabetes. This presentation is brought to you by the University of California, Davis, Lawrence Livermore National Laboratory Point of Care Technology Center. We are an NIH-funded site, specifically by the NIBIB. This is Rebecca Sonu, and I am a postdoctoral fellow in the center. This lecture is outlined as follows. Section 1 will define hemoglobin A1c, report some current research on hemoglobin A1c variability, and present a standardization program for A1c methods. Section 2 will cover some current global facts on the diabetes epidemic and will present an effective point-of-care model program called QAMS in Australia. This program was successful in their effort to curb the rise of diabetes and its associated costly complications. Section 3 will present some current point-of-care technologies for diabetes monitoring and treatment. Section 4 presents the current recommendations for using hemoglobin A1c for diagnosis of diabetes. This was made by the International Expert Committee. Section 5 will present the current controversy with using point of care for hemoglobin A1c. Lastly, Section 6 will present some policy recommendations for using hemoglobin A1c in small rural networks and also in low resource settings. Section 1, hemoglobin A1c, definition, variability, and standardization. When blood glucose enters red blood cells, it glycates the amino terminals of hemoglobin, making glycosylated hemoglobin. This is also known as hemoglobin A1c. Since the half-life of the red blood cell is typically 60 days, the level of hemoglobin A1c reflects the mean blood glucose concentration over the preceding 2 to 3 months. Hemoglobin A1c can be reported as a percentage in NGSP or DCCT units, or in IFCC units, in millimoles per moles. DCCT stands for Diabetes Control and Complications Trial. NGSP stands for National Glycohemoglobin Standardization Program, and the IFCC stands for the International Federation of Clinical Chemistry. The corresponding estimated average glucose values are shown on the table. The estimated average glucose can be reported in either milligrams per deciliters or millimoles per liters. The current status regarding the units of hemoglobin A1c is that there is an official worldwide consensus that hemoglobin A1c should be reported in both NGSP and IFCC units, along with the estimated average glucose. However, the decision on what to report is being made country by country and thus varies globally. For example, in the United States, the American Diabetes Association and American Association for Clinical Chemistry recommends reporting results in NGSP with the estimated average glucose. The world will eventually report results in IFCC units. Even though countries differ in reporting A1c results, the results can be traceable to IFCC and NGSP results through linear equations, which will be shown later in this presentation. These linear equations are carefully monitored twice a year. These formulas can be found on the NGSP website shown below. Hemoglobin A1c variability. When clinicians order hemoglobin A1c levels for their patients, it is imperative that caution is taken for those that have conditions which alter red blood cell lifespan. Since A1c reflects the percentage of glycated hemoglobin in red blood cells in the body, an altered red blood cell lifespan will give misrepresentative results. Therefore, take extreme caution in those patients with hemolytic anemia, severe iron deficiency anemia, and chronic renal failure. Clinicians should also particularly take caution for patients with hemoglobin variants, such as sickle cell disease or trait, or for those who've had recent blood transfusions, and also for those patients that are pregnant. Aging may also show variability in A1c results. Pani and authors showed that A1C levels are positively associated with age in non-diabetic populations. The study involved non-diabetics ranging in age from younger than 40 years old to over 70 years old. They found that for every 1 year increase in age, there was an approximately 0.03% increase in A1C levels in non-diabetic individuals. They concluded that this small change is unlikely to make it necessary for treatment goals to differ for the different age groups. Another study by Herman and authors concluded that A1C levels are higher among certain U.S. racial and ethnic minority groups with impaired glucose tolerance after adjusting for factors likely to affect glycemia. However, these variation between ethnic groups is quite small and thus may not be clinically significant. Even gender and smoking status has also been claimed to cause variability in A1C results. Although these variabilities may exist, the clinical impact that hemoglobin A1c test provides in preventing diabetic complication outweighs the clinical impact that these variabilities may cause. The International Federation of Clinical Chemistry Standardization of Hemoglobin A1c. The IFCC has developed reference methods for hemoglobin A1c analysis. For the primary reference material, mixtures of pure hemoglobin A1c and pure hemoglobin A0 are used to calibrate the reference method. The IFCC reference method has 3 steps. In the first step, hemoglobin is washed and lysed from erythrocytes and is cleaved into peptides by the proteolytic enzyme endoproteinase GLUC. The resulting glycated and non-glycated N-terminal hexapeptides are then separated from the crude peptide mixture by HPLC, or high-performance liquid chromatography. In the third and final step, the glycated and non-glycated hexapeptides are quantified by mass spectrometry or by capillary electrophoresis with ultraviolet detection. Hemoglobin A1c is defined as millimole of glycated hexapeptide per mole, which the mole is the total of glycated and non-glycated hexapeptides. For more information regarding the IFCC reference methods and laboratory network, please access the website listed down below. The master equation listed below links the IFCC results to the clinically meaningful hemoglobin A1c results from the DCCT or NGSP results. This equation provides the NGSP units with traceability to the higher order IFCC reference method. National Glycohemoglobin Standardization Program, or NGSP. The NGSP program purpose is to standardize glycated hemoglobin test results so that clinical laboratory results are comparable to those reported in the DCCT. The DCCT has established relationships to mean blood glucose and the risk for vascular complications. A key component of the program is the reference laboratory network. The network consists of an administrative core called NetCore, a central primary reference laboratory, primary and secondary reference laboratories. The primary reference lab serves as a backup lab to the central primary reference lab and is quality controlled by the central primary reference lab. The Central Primary Reference Lab analyzes the glycated hemoglobin by HPLC using BioRex 70 resin, following the existing laboratory method protocol, and sets the initial calibration for the standardization program based on the set point used in the DCCT. The second reference laboratory works with the manufacturers and assists them in standardization of their methods, and then in providing comparison data for certification and traceability to the DCCT. Performance monitoring of these primary and secondary labs are done on a monthly basis and are required to fulfill bias and precision requirements. For manufacturer certification, Manufacturers must participate in a fresh blood sample comparison of 40 samples of specific reagent lots, calibrator lots, and instrumentation for the estimation of bias from the standard reference lab. The A1C method is then required to agree with the reference method within plus or minus 0.75% at the 95% confidence interval. Methods should be recertified annually. The NGSP website also lists which methods are and are not affected by hemoglobin variants, such as hemoglobin S for sickle cell anemia, hemoglobin C, and hemoglobin E and D. If the patient has a variant, it would be good practice to ensure that the method that's being used to measure the A1C levels is not affected by that particular variant. The National Glycohemoglobin Standardization Program is global. As you can see in the map, there are 87 NGSP certified laboratories. There are 72 level 1 and 15 are from level 2. 21 labs are from the United States and 66 laboratories are outside the United States. An external quality assurance program refers to a system in which laboratory results are scrutinized objectively by an outside agency in order to get a general impression of the standard of laboratory practice and to achieve inter-laboratory comparability. In Australia, the Royal College of Pathologists of Australasia, or RCPA Quality Assurance Program, uses human blood as a control specimen. Currently, there are approximately 320 laboratories enrolled in this program. Each analyte, such as A1C, will be measured 12 times per cycle, and each cycle is 6 months. Participants may report A1C units in percentage or millimoles per mole. The target values are assigned with the DCCT method and the IFCC reference system. The acceptable range for results is determined by the allowable limits of performance, which are clinically based limits set by the program organizers. They indicate a range from a target value within which the quality assurance program results are expected to fall. The Australian Government National Pathology Accreditation Advisory Council, or NPAAC, defines the acceptable performance as the level of performance above a minimum standard. Currently, the allowable limits performance for hemoglobin A1c for laboratory performance is plus or minus 0.5% for A1c levels equal to or less than 10%, and plus or minus 5% for A1c values more than 10%. This latter allowable limit of plus or minus 5% may need to be considered for a stricter range. Bio-Rad also offers an external quality control program on the QCnet. For glycated hemoglobin, they offer the LipoCheck Hemoglobin A1c linearity set, which also uses human whole blood. 4 significant hemoglobin A1c levels are measured, one being 2.5 to 4%, second being 5.0 to 7.0%, the third being 9 to 12.5%, and the fourth level being 17 to 22%. A software tool is also available online. Additionally, LipoCheck Hemoglobin A1c control is also available. This control is a human whole blood-based product designed to monitor the performance of automated and manual procedures for the measurement of hemoglobin variants, including hemoglobins A2, fetal, and S. It is very important that external quality control testing is required wherever methods are being used to measure A1c levels. Appropriate quality control will require the methods being used to have small coefficients of variance and high precision. Each lab should prepare and purchase their own quality control specimens and set their own limits and acceptance criteria for the specific laboratory setting that they're in. In a recent publication released in November 2009 in the journal Clinical Chemistry, Lunters, Westra, and authors showed that only 6 out of 8 hemoglobin A1c point-of-care instruments met the general accepted analytical performance criteria. The 2 instruments that met the acceptance criteria were Afinion and DCA Vantage for having a total CV of less than 3% in the clinically relevant range. The global epidemic of diabetes and an effective point-of-care model program. In the June 2008 fact sheet press release, the Centers for Disease Control and Prevention announced that there was an increase of 3 million people with diabetes in the United States in just 2 years. Now, the United States has an estimated 24 million, or about 8% of the population, with the disease. An estimated 57 million people are pre-diabetic and are at risk for diabetes unless there is intervention. Since 2002, the direct medical cost of diabetes has increased by $24 billion in just 5 years. This totals to $116 billion. The indirect costs increased by $18 billion, costing the United States a total of $58 billion. These costs include disability, work loss, and premature death attributable to diabetes. Diabetes is a very expensive disease, costing the patient 2 to 3 times more in medical expenses than a non-diabetic patient. The United States ranks 3rd in the top 5 countries with the highest diabetes prevalence, with India ranking 1st, followed by China for 2nd. Diabetes is a global epidemic that is occurring in both developed and underdeveloped countries. The costs associated with diabetes in the U.S. are tremendous. In other countries, such as Thailand and Australia, where diabetes is also on the rise, what are the costs associated with diabetes? Will the national health burdens increase? If so, by how much? According to the World Health Organization, the prevalence of diabetes is estimated to substantially increase by 2030. Currently, Asia leads in the global diabetes epidemic, with India ranking 1st and China leading with 2nd. 2 other Asian countries also make the top 5, Indonesia and Japan. The conception that diabetes was a disease of the well-developed countries no longer holds true. The diabetes epidemic is also affecting developing countries as well. For example, in Thailand, a study was done to determine the prevalence of diabetes in Thai adults aged 35 years and older. They found that the estimated prevalence of diabetes is about 2.4 million people, or 9.6% of the population. They found that there were no difference in prevalence rates of Thai men versus women, and that urban versus rural areas do not differ. Factors that can explain the increase in diabetes include the socio-demographic factors such as the greater age of the population, the increased proportion living in an urban environment, and mounting levels of obesity. Overall, they concluded that diabetes is common in Thailand and that only 50% of the cases were included in the study, meaning that the actual prevalence rates are even higher. They also conclude that rates will continue to increase over the next few decades. Therefore, initiatives to increase the diagnosis of diabetes leading to treatment would produce substantial health benefits in Thailand. In 2006, the United Nations recognized type 2 diabetes as a serious epidemic for which urgent steps to improve management and disease prevention are needed. They have called for member states to develop national policies for the prevention, treatment, and care of diabetes in line with the sustainable development of their healthcare systems. This public health advisory defines the problems, positions point-of-care testing in regional healthcare, and provides integrated solutions. Australia is another country where the diabetes prevalence is on the rise, especially in remote and rural areas where medical care is not easily accessible. In an effort to control the increasing problem of diabetes, Dr. Mark Shepard and his team started QAMS, which stands for Quality Assurance for Aboriginal and Torres Strait Islander Medical Services. Their mission is to provide culturally appropriate and clinically effective diabetes management to Aboriginal and Torres Strait Islander people through the use of point-of-care testing for A1c and urine albumin creatinine ratio. This is conducted under a quality management framework. In this study titled Point of Care for Hemoglobin A1c and Blood Glucose in a Remote Aboriginal Australian Community, point-of-care devices used for diagnosing and managing diabetes were assessed. Type 2 diabetes and its associated complications are the major cause of premature mortality in this community. Therefore, it is crucial for point-of-care devices to be implemented into provided medical services. But in order to be effective, these devices must be accurate and reliable in the hot and humid conditions that are characteristics of this remote location. This cross-sectional study compared point-of-care capillary glucose and hemoglobin A1c results with those from venous samples measured in a reference lab. The study included 152 residents aged 11 to 76 years old and used the point-of-care HemoQ glucose 201 and the Bayer DCA 2000 plus analyzers. Fingerstick samples were taken from each participant, then had venous blood drawn for subsequent measurement of A1c and glucose levels in a reference lab that was flown 300 kilometers away from the site. The point-of-care analysis was performed in a room open to the outside, hot and humid environment. Statistical methods include least squares linear regression, two-tailed student's t-test using paired differences, and the Blandin-Altman plot. For hemoglobin A1c, the values obtained by the point of care were statistically, analytically, and clinically identical, thus stating that the Bayer DCA 2000 Plus device is accurately acceptable for field use in this remote community. The precision could not be assessed due to the small sample size, but this importance was noted. For glucose measurements, the point-of-care device versus the reference laboratory were reasonably correlated. But it did show a concentration-dependent difference. Therefore, it was concluded that the diagnosis of diabetes still must rely on reference laboratory values. So is point-of-care technology adaptable and transferable? According to the study, yes, the Bayer 2000 Plus analyzer is accurate and acceptable for measuring hemoglobin A1c and for measuring urine albumin creatinine ratios in the hot and humid conditions in Australia. This figure shows the average width and sight and precision achieved for external quality assurance of hemoglobin A1c and urine albumin creatinine ratio, point-of-care technology, in all 4 participating services over the following years. A1c and albumin creatinine ratio levels of imprecision readily met the precision goals, except for one time point in A1c during 2004. This figure shows that patients were more satisfied with services for managing their diabetes before and after the introduction of the point-of-care program. Satisfaction rose from 64 to 88%, whereas the percentage who were either unsatisfied or unsure about their diabetes service fell from 8 to 3% and 28 to 9% after point-of-care technology had commenced. Overall, the Point of Care and Aboriginals Hands program was successful due to the excellent commitment from the staff and management and the program's overall ability to be transferable and adaptable. In a remote Aboriginal Australian community with high diabetes prevalence, the implementation of point-of-care technologies for diabetes was successful and effective. Utilizing point-of-care technologies to test for diabetic complications such as nephropathy and cardiovascular disease is crucial for patient welfare. This case study serves as a model for remote and rural communities with high disease prevalence and inaccessible medical care. Well-structured and efficient point-of-care technology programs will close the gap between remote versus urban locations and will ensure consistent strategy for primary national healthcare systems. Due to the successful implementation of point-of-care programs in the Aboriginal communities in Australia, the Australian government has funded the QAMs a total of $3.8 million through until 2013 to fund the support the expansion of services to 170 programs. The expanding programs include the Northern Territory of Australia using the Abbott iStat point-of-care device in 30 remote health centers. The Western Desert region will be using the HemoQ DM201 device to identify and monitor anemia. Both devices will be networked to a central data station where all point-of-care technology results will be electronically sent to remote health centers. Also, a new partnership with Roche in New Zealand for warfarin management with the use of Coagucheck XS has been planned. Point of care for diabetes. The goals of point-of-care testing are to improve medical and economic outcomes and to decrease therapeutic turnaround time, which is the time from test order to patient treatment. The Principles and Practice of Point-of-Care Testing, edited by Dr. Gerald Koss and published by Lippincott, Williams, and Wilkins, can provide a comprehensive overview of point-of-care testing. And Wilkins. Point-of-care testing, which is defined as medical testing at or near the site of patient care, encompasses several different instruments. Instrument formats include portable, transportable, benchtop, and near the patient monitoring devices, disposable tests, and handheld instruments. Some methods are single-use, disposable, while others are cartridge-based or multi-use. This slide shows some of the commercial point-of-care tests available out in the market. The devices on the upper right box are those that test only for urine albumin. The bottom box on the left tests for only A1c. The box in the middle are devices that can test for both assays. The A1c now, DC Advantage, HemoQ, ImmunoDip, and MicroTest all use immunological methodology. The Affinion, the NicoCard, the Intuit uses a boronate affinity methodology, and the Clinitic Status, MicroAlbustix, and UriTest 13G all use the colorimetric method. Also note that the A1c devices, including the devices that measure both assays, have been NGSP certified in 2009. The Hemoglobin A1c reagent kit by Siemens is to be used with the Siemens DC Advantage, DCA 2000 Plus, and Siemens cartridges. The test is only CLIA waived when used with these devices. The disposable reagent card requires only 1 microliter of whole blood, which is to be inserted into the portable instrument pictured on the slide. The results take only 6 minutes. The normal range for hemoglobin A1c using the DCA A1c test was determined by assaying blood samples from 103 apparently healthy individuals. The range was 4.2% to 6.5%. The precision was determined by multiple DCA 2000 assays of 2 different commercially prepared whole blood controls that were performed by 3 independent investigators. Within-run precision was evaluated by including normal and abnormal controls in duplicates in each run of clinical specimens. The correlation coefficient was determined by using the DCA 2000 A1c system in ion exchange high-performance liquid chromatography, or HPLC. Multiple assays were done, and the correlation coefficient ranged from 0.97 to 0.98. This indicates a value that shows a very good correlation when compared to the reference. The analytical measurement range is 2.5% to 14% in A1c. The CLIA waiver accuracy study included 68 participants with no previous lab experience to perform the test. The results were compared to the target values traceable to the HPLC reference method. The target levels were within range of the 95% confidence intervals, except for 8.18%, which is only off by 0.06%. 0.02%. Please keep in mind that this device was CLIA-waived on the intended use of monitoring and treatment of diabetes and not for diagnosis. CLIA waiver for diagnosis would require a new submission to the FDA. These hemoglobin A1c assays can be significantly clinically useful for predicting diabetic complications. For example, peripheral arterial disease is a major common complication of diabetes. It is defined as a clinical disorder in which there is a stenosis or occlusion in the aorta or arteries of the limbs. The primary sites of involvement are the abdominal aorta and iliac arteries, the femoral and popliteal arteries, and the more distal vessels, including the tibial and peroneal arteries. It has been found that elevated A1c levels in diabetics are positively associated with an increased risk of peripheral arterial disease. Hemoglobin A1c levels of greater than 7.5% were more than 5 times more likely to develop intermittent claudication and or require hospitalization versus hemoglobin A1c levels of less than 6.0%. Overall, A1c levels can predict symptomatic and asymptomatic peripheral arterial disease in diabetics. Selvin and authors also found that A1c levels are independently related to carotid intima media thickness and coronary heart disease. Since intima media thickness is a widely accepted marker of atherosclerosis and is a predictor for coronary artery disease events, hemoglobin A1c can also be used to predict risk of coronary artery disease. In addition, A1c levels are also related to race, ethnicity, adiposity, lipid levels, hormone therapy, and diabetes treatment. These factors must also be considered when using the A1c assay. One of the other major complications of diabetes is diabetic nephropathy, which can lead to end-stage renal disease. Microalbuminuria predicts the development of glomerular damage in the absence of overt nephropathy. Therefore, major renal damage can be prevented. Point of care for urine microalbumin can rapidly, reliably, and easily detect early manifestations of disease and helps to manage diabetic patients effectively. The Siemens DCA Systems microalbumin creatinine reagent kit is a point-of-care kit that can be used with the portable Siemens DCA Vantage Analyzer or DCA 2000 Plus. It can give albumin, creatinine, or albumin-creatinine ratios in just 7 minutes. It requires a disposable reagent card, which requires only 40 microliters of urine. According to the package insert, it is recommended that each laboratory is to establish their own reference ranges due to the differences which may exist between laboratories and locales with respect to population, diet, lab technique, and selection of reference groups. The range of 16 to 37 milligrams per liter of urine albumin was considered the upper limit of the normal range due to studies conducted by Siemens. The precision of the assay was determined by multiple DCA 2000 microalbumin and creatinine assays of 2 different commercially prepared artificial urine-based controls that were performed by 3 independent investigators. Within-run precision was evaluated by including low and high controls in duplicate in each run of clinical specimens. Siemens also offers the Clinitec microalbumin reagent strips. There are 2 strips offered to be used on the Clinitec Status and Clinitec 50 analyzers. The microalbumin 9 strips is a urinalysis test strip that tests for 9 different analytes: albumin, blood, creatinine, glucose, ketones, leukocytes, nitrate, pH, and protein in the patient's urine. Another type of strip, called the microalbumin 2 strips, is a urinalysis test strip for just 2 analytes, albumin and creatinine. This is a better option for low-resource areas where funding for the 9 analyte strip may not be available. For the performance characteristics, the microalbuminuria is known to be in the range of 20 to 200 milligrams per liter. The microalbumin 9 and 2 strips are pretty highly sensitive. They can detect microalbuminuria in the range of 20 to 40 milligrams per liter, as shown in contrived urine. More than 150 milligrams per liter may indicate clinical albuminuria in these strips. Normally, a level of more than 200 micrograms per liter is considered clinical albuminuria. The creatinine is in the range of 10 to 300 milligrams per deciliter, can be detected by these strips in the same range of 10 to 300 micrograms per deciliter. More information can be found in the Siemens Clinitec microalbumin reagent strips package inserts that can be provided by the manufacturer. Section 4, the International Expert Committee Recommendations for Hemoglobin A1c and Diagnosis. In July 2009, the International Expert Committee, which comprises of members from the American Diabetes Association, the European Association for the Study of Diabetes, and the International Diabetes Federation, released a report on the role of hemoglobin A1c assay in the diagnosis of diabetes, in the hopes that it will serve as a stimulus for consideration to be used for the diagnosis of the disease. The International Experts Committee has assigned a hemoglobin A1c of 6.5% or higher as the optimal value for the diagnosis of diabetes. This value was determined from a study that showed that a hemoglobin A1c of 6.5% or higher resulted in moderate retinopathy, whereas subjects with an A1c level of less than 6.5% showed no signs of moderate retinopathy. Some of the other points that were noted were hemoglobin A1c correlates well with the risk of long-term diabetes complications. When hemoglobin A1c is greater than or equal to 6.5%, the diagnosis should be confirmed with a second repeated A1c test. Hemoglobin A1c assays provide accurate and precise measurements of chronic glycemic levels. If A1c testing is not possible, previously recommended diagnostic methods are acceptable. The A1c testing is indicated for children in whom diabetes is suspected, but classic symptoms and plasma glucose of over 200 micrograms per deciliter are not observed. Recommendations for A1c and diagnosis. More recommendations for patients at risk for diabetes include the patients with A1c levels of greater than or equal to 6% to 6.5% should receive intervention to prevent deterioration and complications. Impaired fasting glucose and impaired glucose tolerance do not reveal the true continuum of risk. Risk assessment based on A1c levels follows trends, so monitoring frequency must balance the medical objectives, actual outcomes, and cost effectiveness. Some of the advantages for A1c include that A1c is standardized and aligned with the DCCT UK PDS, has substantially less biologic variability, has substantially less pre-analytic instability, has no need for fasting or time samples, is relatively unaffected by acute perturbations in glucose levels, gives better index of overall glycemic exposure and risk for long-term complications, and is currently used to guide management and adjust therapy. Overall, the committee focused on the advantages of using A1c in comparison to glucose measurement for the diagnosis of diabetes, and secondly, the idea that we should diagnose diabetes based not on some absolute glucose level, but on the clinical implications of long-term abnormal glucose control and its relationship to organ disease. So let's bring the problem of diabetes into low-resource countries or in remote and rural areas where handheld meters frequently represent the only instruments available for glucose measurements. Using point of care will enable these areas to control the diabetes epidemic. By using point of care for hemoglobin A1c, clinicians can rapidly and effectively screen, diagnose, and monitor the patient for efficient diabetes care. Here are some points to consider. Hemoglobin A1c can facilitate early diagnosis of diabetes and reduce the frequency of diabetic-related complications. At diagnosis, 25% of patients already present with diabetic retinopathy or microalbuminuria. The advantages of A1c versus fasting plasma glucose are: A1c does not require patient fasting. A1c levels are not affected by lifestyle changes. A1c testing allows for same-day diagnosis and relieves the need for repeat plasma glucose testing. An intra-individual variability of A1c is considerably lower than that of fasting plasma glucose. Some disadvantages are the precision and accuracy of point-of-care A1c tests that are being questioned. There are limited studies, and the cutoff value has not yet been established. This leads us into Section 5. Point of care for hemoglobin A1c and diagnosis, the current controversy. Currently, there is much concern regarding the use of point of care for A1c for the diagnosis of diabetes. The International Expert Committee noted in their recommendations that were just stated that A1c tests to diagnose diabetes should be performed using clinical laboratory equipment, and that point-of-care instruments have not yet been shown to be sufficiently accurate or precise for diagnosing diabetes. The 2009 NGSP Clinical Advisory Meeting Notes also stated there is much concern regarding the lack of data on point-of-care methods. These methods are mostly CLIA-waived. They do not have to participate in the CAP survey. These tests are used widely in developing countries, and the performance of these devices need to be known. Also, the manufacturers would have to apply to the FDA for their methods to be used in diagnosis. These methods could be unwaived for diagnosis. Point-of-care testing is not an excuse for inaccuracy. All medical testing must be accurate no matter where it is performed and by whom. The point of care has been shown to be useful in monitoring and treatment in diabetes. Peterson and authors reported that point of care for A1c testing has exhibited both short-term and long-term effects by lowering A1c levels. Dr. Mark Shepard has also shown that introducing point-of-care for A1c in a remote town of Victoria has also resulted in long-term reductions in A1c. This point-of-care technology has great potential to curb the global diabetes epidemic. If point-of-care were to be shown to be accurate enough for the diagnosis of diabetes, then using point-of-care for the diagnosis of diabetes, along with the current recommendations, may contribute to even a greater impact in reducing the prevalence and incidence of diabetes around the world. Early diagnosis of diabetes is imperative for the prevention of complications, and the A1c methods can aid in this prevention. Not only is it useful for point-of-care technology to be used in low-resource, remote, or rural areas, but the emergency department is also another setting where rapid point-of-care technology can also be effective in diagnosing diabetes, especially in emergency departments in urban settings where patients are found to be at high risk for disease. The current diagnostic criteria for diabetes using fasting glucose or glucose tolerance tests are impractical in the emergency department. The study showed that 29% of emergency department patients undiagnosed for diabetes had abnormal A1c levels, in which the majority of them were confirmed as being pre-diabetic or diabetic. Therefore, the study by Ginn and authors showed that diabetes screening using point-of-care for A1c and random fasting glucose can be effective. Overall, the emergency department represents a setting where point-of-care technologies are practical and very useful. Point-of-care provides immediate results available at the site of patient care and minimizes therapeutic turnaround time. Point-of-care technologies are also important in low-resource settings, non-laboratory environments in remote and rural locations, and emergency disaster settings, which are also implications for opportunistic screening for diabetes. Section 6, titled Policy Recommendations for Hemoglobin A1c in Small Rural Networks and in Low-Resource Settings. This slide lists some reasons for why point-of-care technology can be used strategically in certain areas such as small rural networks and low-resource settings and areas that are remote and rural. Point-of-care for hemoglobin A1c microalbumin testing can work synergistically. They are rapid and reliable, convenient for immediate decision-making, advantageous for the high prevalence of disease in the location. Preventative and personalized Medicare can be provided. They are versatile and adaptable to different locations and contexts, and they can be cost-effective for sustainability. Hemoglobin A1c demonstration projects can facilitate ownership. It can provide effective strategy for both patients and public health care. But professional working groups can provide the necessary leadership, and laboratories must assure the accuracy of testing. The next 3 slides will offer policy recommendations. The first recommendation is to develop low-cost, highly accurate glucose and hemoglobin A1c technologies. Set analytical goals for point-of-care technology performance for diagnosis, monitoring, and treatment of diabetes that is appropriate for the laboratory or non-laboratory environment. Include precision, accuracy, bias, and total allowable error in terms of CV. Secondly, assess performance using the new locally smooth median absolute difference curve method. Utilize available standardization programs. Include point of care for hemoglobin A1c performance validation and proficiency testing. Develop free online education programs for safe and efficacious point of care technologies. The second policy recommendation is to implement point of care A1c testing for strategic advantage. Use A1c for rapid screening, primary diagnosis, and trend monitoring and therapeutic compliance. If A1c of greater than or equal to 6.5%, diagnosis should be confirmed with second A1c testing, unless the clinical symptoms and glucose levels of greater than 200 milligrams per deciliter are noted. Establish specific criteria for screening that will prompt further evaluation. Report the A1c values in IFCC in millimoles per mole, in DCCT or NGSP in percentage, with the estimated average glucose in milligrams per deciliter. Test up to 4 times per year based on risk level, plus check quality control results. Add urine microalbumin, creatinine, and other tests to predict complications. The third main policy recommendation is to optimize knowledge by connecting small world networks. Establish computerized connectivity of point-of-care results within the small world networks. Link the results to regional healthcare delivery systems, and integrate mobile units, primary care, and community hospitals and regional centers by means of telemedicine. Optimizing diabetes care workflow in low-resource small world networks. In low-resource settings where the prevalence of diabetes far outweighs the medical resources available for effective management and treatment, diabetes care should first incorporate the best therapy practice that incorporate the use of A1c for management. In the journal Diabetes Care, Nathan and authors published a consensus statement titled Medical Management of Hyperglycemia and Type 2 Diabetes, a consensus algorithm for the initiation and adjustment of therapy. This paper offers very helpful guidelines for the medical management of hyperglycemia, shows a summary of glucose-lowering interventions, a flowchart on the initiation and adjustment of insulin regimens, and recommendations for the titration of metformin. This paper offers the guidelines that should be highly considered when managing patients with uncontrolled diabetes. While every patient with diabetes or at risk of diabetes should all receive the proper care and treatment from physicians, some low-resource settings that are understaffed with physicians, nurses, and pharmacists must strategically plan the diabetes care workflow to accommodate the overwhelming number of patients with the disease. First, within the Small World Network, the highest quartile of the diabetes population with the worst controlled diabetes, as indicated by the highest range of A1c values, should be seen at the community hospital, where patients can be seen by intensive physicians along with pharmacist management. Here, fasting plasma glucose measurements can be taken along with the proper adjustments to therapy as recommended by the consensus statement by Nathan and authors. For the diabetic population with the second highest quartile in median hemoglobin A1c values, patients should be seen in the primary care units where nurses and primary care unit staff take responsibility and use evidence-based decision-making on the management of these patients. On clinic days, determine hemoglobin A1c at the point of care in primary care units when a rotating team of physicians, pharmacists, and medical technologists can see patients quickly and meet their diabetes managing needs. Lastly, for the diabetic population with the median A1c values and for single patients, manage the patients down to the recommended levels as stated in the Diabetes Care paper published in 2009 titled The International Expert Committee Report on the Role of the A1c Assay in the Diagnosis of Diabetes. Patients who manifest complications should be identified, and prevention can be accomplished by screening for microalbumin and albumin to creatinine ratios in the urine. This concludes the presentation titled Point of Care for Hemoglobin A1c Testing Provides Strategic Advantage for the Monitoring and Treatment of Diabetes. Thank you for listening.